And this brings me to an important point. So, you know, as you can imagine, Laura, in oncology, it's all about shrinkage, tumor markers, etc. And sometimes we struggle in kind of explaining survival. And from your standpoint, especially if we're going to try to include that serotic component, how can we reach to the patient and make sure that the message about improvement in survival is there?
Well, it can be difficult because, as Rich had originally said, we're dealing with two diseases. So explaining to the patients that both those diseases are competing with each other to cause them harm and decrease their overall survival, and letting them know that if they do not have a curative option is very important, so that their expectations are not that this tumor is going to go away. And from there, I think telling patients that this drug has shown survival. It's the only drug that is currently available at this point in time that has shown survival, is very important, because a lot of times we're trying to get patients on drugs and they show up and they're the ones who don't want to start. They hear the side effects, you tell them about manageability, they don't want to come back in 10 days to be seen again, they're traveling far. I have found as a hepatologist treating people that if I set them up with an oncologist closer to home in the community, that has worked very well. Patients are a lot more amenable to saying, okay, well, I'll go see this guy who lives 5 miles away from me in 10 to 2 weeks and follow up. Because I don't feel comfortable saying, okay, come back in 3 months after you've just started them on a biological agent. But I think that telling them that this is not going to cure them, but the hope that they're going to have improved not only length of time, but hopefully quality of life by decreasing some of their symptoms, such as pain, can drive that point home to patients.
Sure, sure. So, you know, with sorafenib on board, and I think Richard mentioned that there was a lot of, to be fair, genuine and serious attempts to see if we can improve on the survival beyond the 10.7 months that we just heard from Kitty. And interestingly, we were all kind of, you know, involved in those efforts. They are very noble efforts, and really nothing worked. And then, out of nothing, I have to say, you know, this is hot off the press. The Lancet, you know, just literally 7 January, just a few days ago, regorafenib for patient with HCC who progressed on sorafenib, randomized double-blind, placebo-controlled phase 3 trials. So you are part of that study. Tell us first about the results, and let's discuss it a little bit further.
Well, the RESORCE study is the light at the end of the tunnel for us, I think, in liver cancer, given that we've had about 10 years without a new drug, without a positive phase 3 study. And you allude to the fact that maybe this was a dark horse in the race, but in retrospect, maybe it wasn't. You know, regorafenib, like sorafenib, is a multi-targeted therapy. It hits several kinases, but differentiates itself a little bit. It's a very potent pan-VEGF inhibitor, including VEGFR2, as well as Tie2 receptor, which plays a role in angiogenesis.
And if I may add here, it was actually designed to do that. In other words, the intent was, when the regorafenib was designed, is to actually improve or cash on more targets than sorafenib.
Correct. And I think we need to be humble when we approach drugs like this. We might not know exactly what they're doing. Regorafenib was approved already, shown to be an anti-cancer drug in colon cancer and also in GI stromal tumors, where it hits the c-KIT receptor. There was a phase 2 study led by Jordi Bruges out of Barcelona, a very well-conducted study defining patients who had progressed on sorafenib with a clear definition of that, excluding patients who were intolerant. And they had a very provocative median survival, not looking at response rates per se, although those were reported and they were higher than with sorafenib. But needless to say, the survival is in the 13, 14-month range. And we know now from many of the negative phase 3 studies in second line that median survival for this population was about 8 months. And if we look at the development of sorafenib, your work in a large phase 2 study showed a survival of about 9, 10 months, and that was the signal to move that drug ahead in frontline. So the regorafenib study, I think, besides taking a new molecule into second line, also learned from some of the clinical trial design errors that maybe occurred in some of the other phase 3 studies. They had a benchmark for what to expect in second line, that 8 months, which I think surprised a lot of people when we looked at the Brivinib data, the first drug to read out in the post-sorafenib era, being around 9 months. No one really expected that. But also dealing with all the other prognostic factors in second-line HCC that are important to stratify for and control for, such as high alpha-fetoprotein. We saw that in the ramucirumab data, that's an important prognostic factor. And maybe separating macrovascular invasion and extrahepatic spread instead of lumping them together as we saw in the Brivinib and in the everolimus experience. Needless to say, this was a well-conducted, randomized, phase 3, double-blind, placebo-controlled study of regorafenib, 160 milligrams orally, daily on a 3-week on, 1-week off regimen versus a placebo on the same regimen. And this was a positive study for overall survival, improving overall survival by about 3 months. We saw an improvement from about 8 months to just under 11 months. It has a ratio of 0.63, which is a 37% decrease in the risk of death. A lot of this was managed similar to sorafenib with prolonging stabilized disease, but interesting enough, the response rate was higher with this drug. So clearly this is a different drug than sorafenib, that once patients are progressing, and what is progression on sorafenib? That's something we've wrestled with for a while for a drug, as Katie pointed out, has no response rate really. So when do we say patients are progressing? And in this study, we said resist progression, so more than 20% increase. And at that point, randomizing them to the two control arms. And we saw that there was a response rate, a real response rate by RESIST of 10% with regorafenib. So taken together, its mechanism of action, which is differentiated from sorafenib, and the response rate, I think we can confidently say that this is establishing potentially a new standard of care in second line once the drug receives regulatory approval.
Fascinating story. If anything, I would say that, doctors, we're all doctors, we're not really early adopters sometimes, we question things, but we read really with a lot of interest the paper from Dr. Bruges in The Lancet, and it's fascinating because one of the questions or the doubts that was raised, how long patients have been sorafenib, could you be just kind of passing from sorafenib to regorafenib? Believe it or not, actually patients were on sorafenib for at least 7 months before they progressed and moved to the regorafenib. And the second question was maybe these are highly selected patients with really great outcome, and maybe there was a long delay between the stop of the sorafenib start of the regorafenib. This was only 28 days. So this is real story, and add to this what was not really a appropriately designed analysis, but nonetheless it's kind of bring a quite intriguing point, is that the sorafenib followed by the regorafenib together will clump something close to 24-month median survival. It's quite a fascinating story, which obviously we're trying to understand from the biologic standpoint, really what is the really setup over here that kind of led to that improvement in outcome. Is it really just different biology? Is it the prepping the field? Is the sequence important? So these are all questions that we are all looking into and raising.